Fortunate to have Dr. Benjamin Joseph, sir, as a beginner of this module. And he does not need any introduction that we all know him, we all have learned, we all read his work and then started practicing Bennett-Perthes disease or congenital pseudoarthrosis tibia or learning the natural history of flexible flat feet in Indian children. And I particularly have read his book on paralytic foot and learned this concept from his work, and have tried to teach my fellows how to evaluate a paralytic foot and how to approach it. So he's the best person to teach you, and I'm sure you all will learn this. Dr. Joseph sir is the founder member of Pediatric Orthopedic Society of India, and we all are learning and in getting inspired from him. Good morning, sir. Welcome.
Morning. Good morning. Thank you.
And along with Dhiren Bhai, we welcome you to the Orthokids Fellows Teaching Module. Kindly share your screen and start. We have didactic talk. It will follow by some discussion and a couple of interesting cases we'll try to present at the end, if time permits.
Can you see my screen?
Yes, sir. Please share your screen.
Okay, can you see?
Yes, it is loading. Yes.
Okay. Is that okay?
Yes, it's imperfect.
Okay. So I'm going to talk briefly about management of the paralytic foot in children. If you now look at the features of a normal foot, you'll be able to understand what are the problems that might occur in a paralyzed foot. A normal foot enables a plantigrade tread. By plantigrade, I mean the forefoot and the hind foot rest on the ground in the normal way. The arch is maintained. When you look at the function of the foot while walking, the ankle dorsiflexes during the swing phase to give you clearance. And then in the stance phase, what we want importantly is stability of the forefoot and the hind foot. In the terminal stance, you want a powerful push-off to enable you to propel yourself forward. When the foot is paralyzed, you might have a deformity with loss of the plantigrade tread. When that happens, the entire sole of the foot may not rest on the ground. Either the front of the foot, the forefoot, the medial side or the lateral side may take excessive contact on the ground, while other areas may not touch. When the child is walking, there might be a foot drop. In the stance phase, there may be instability of the hind foot, particularly the subtalar joint. And the push-off may be weak depending on which muscle is affected. So which brings you to the aims of treatment. We want to make the foot plantigrade. We would like to restore ankle dorsiflexion during swing if there is weakness of ankle dorsiflexion. I would caution you here that sometimes this aim of trying to get active dorsiflexion may not be successful. In that situation, you should at least be able to prevent the foot from dropping. You may not achieve active dorsiflexion.
मैं आपको WhatsApp पे भेज दूं. Easy.
Some mic is on, so I can hear some disturbance. Sorry. So you may not achieve active dorsiflexion during swing, but at least you should be able to prevent the foot from dropping during swing. You need to ensure stability of the ankle and subtalar joint throughout the stance phase. And you should try to facilitate a powerful push-off. Now, the reason why you don't have a normal push-off is usually when there is paralysis of your triceps surae or the gastrocsoleus. And one of the unfortunate things is that no tendon transfer can really replace the gastrocsoleus because that muscle is far too powerful when compared to all the other muscles in the leg. And so you may never achieve a good push-off by tendon transfers, but at least you might prevent something that I'll refer to as a calcaneal hitch, which I'll explain later, which is major abnormality in gait. So how do you correct the deformity? How do you correct the deformity? The deformity may be static or dynamic. If it's dynamic, it's passively correctable. If it's static, it's usually not correct. You need to weaken the deforming force either by doing tenotomy of the offending tendon or by lengthening the tendon. Lengthening the tendon weakens muscle. Or better still, if you can convert the deforming force into corrective force by doing a tendon transfer, you may achieve your aim. If the deformity is static and rigid, a tenotomy or tendon lengthening may not be sufficient. You may have to do bony surgery in the form of an osteotomy or selective arthrodesis, and then do a tendon transfer. It's important to remember that a tendon transfer will not correct a static deformity. It can correct a dynamic deformity, but it will not correct a static rigid deformity. You need to correct the deformity first and then do the tendon transfer. So there's a subtle difference between a static and a dynamic deformity, and you must understand. How do you enable active dorsiflexion in the swing phase of gait? The tendon transfer, if it is successful, you might be able to achieve active dorsiflexion, which was lost in the paralytic process. The next best is you may achieve a tenodesis effect without actually actively dorsiflexing the ankle, in which case the foot will not drop, but it will not dorsiflex during the swing. Now, if these are not possible by any surgery, then at least you will prevent a foot drop by using an appropriate orthosis. And if that is appropriately modified, you may simulate dorsiflexion. How do you ensure stability of the ankle and the subtalar joints? If there is instability because of weakness of some muscles, an appropriate tendon transfer may restore the stability. You may use an orthosis to give stability to the ankle and subtalar joints. And in the older child, you may do an arthrodesis. How do you facilitate a strong push-off? You need to transfer some tendon to the Achilles tendon. And as I mentioned earlier, this is often not very effective because the triceps surae is such a powerful muscle. I said, at least prevent a calcaneal hitch. What do you mean by a calcaneal hitch? In this diagram that I've shown here, you can see on the left that that's what the foot is when it's resting on the ground. But when the child starts walking in terminal stance, when he's about to take the limb forward, there's an uncontrolled translation of the heel on the ground. And the ankle dorsiflexes without control. This is typically referred to a calcaneal hitch. And if you watch people with paralysis of the triceps surae walking, you can see the calcaneal hitch. It's something that must be corrected, particularly if you've got an insensate foot. There's loss of sensation as in spinal bifida. Because when the heel slides forward, as it's shown here in this red arrow, there are tremendous forces on the sole of the foot and friction. And this will lead to ulceration of the heel, which is typically seen in spinal bifida. So that needs to be prevented at all costs. Word on mechanics, there's a word called moment. And a moment is the turning effect of force And that's what, the muscle, what we're really interested in is the moment that is had. How much of a turning effect does it have on a joint? And the moment of force is a product of the force multiplied by the perpendicular distance between the line of action of the force and the center of rotation. In other words, moment is force into distance between the line of action and the force and the center of rotation. This distance is also referred to as the moment arm. Now, moment arms of muscles need to be understood when you're thinking in terms of tendon transfers. Here is a diagram to just illustrate this. I've just drawn the tibialis anterior and the Achilles tendon, shown a red dot to signify the point of rotation of the ankle joint in dorsiflexion and plantar flexion. And then you look at the green lines here, you can see that points to the position of the tibialis anterior and the Achilles tendon at the level of the axis of rotation. And the perpendicular distance is shown above, which gives you an idea what the moment arm is at that point. However, if you go down to the point of insertion of these tendons, you can see that the moment arm is slightly different. And you need to understand the moment arms and be aware what they are like in various tendons around the foot. Here is a model showing the ankle and subtalar joint articulated, and you can see a metallic wire that's passing through. That represents the axis of the subtalar joint. And I've put in 3 tendons. White is the tibialis posterior, the black is the peroneus longus, and the striped one represents the extensor hallucis longus. Now, what are the moment arms in relation to the axis of the subtalar joint?
Line Joseph.
Yeah.
Pediatric surgeon. Manipal.
If you look at the image from the front of this model, you can see the metal wire sticking through the front of the talus. That's the axis of the subtalar. Now, the extensor hallucis longus or the digitorum longus, the tendon runs very close to the axis of the subtalar joint. In other words, the moment arm is negligible or very little. Therefore, it has got very little action on the subtalar joint. As opposed to the tibialis posterior or the peroneal, you can see that they are far away from the axis of subtalar joint. And that explains how they can produce inversion and eversion, because they've got a good moment arm. If this can be altered, then the power of the movement will change. A typical example is, for example, if the peroneus longus tendon subluxates and moves onto the anterior aspect, which occurs in some situations, you will find that a valgus deformity of the foot develops. This is because the moment arm of the peroneus longus increases when it slides onto the lateral malleolus. So the most important part of the lecture is about tendon transfers, because ideally, if you can do a tendon transfer and restore power, that is the ideal situation in a paralytic foot in children. So we need to understand the mechanical basis of tendon transfers. So if you think in terms of the calcaneum, the talus, the normal relationship, you can see that there's an angle between the long axis, which is the talocalcaneal angle. You can see the position of the malleoli. You can see the position of the tendons that run across the ankle joint and the relationship they have with the respective bones. These are the tendons displayed. And to this, we add the axis of the subtalar joint, which runs at an angle of 15 to 16 degrees, medial to lateral as it goes down, and the bimalleolar axis, which is the axis of the ankle. Now, any tendon that runs anterior to the axis of the ankle will act as a dorsiflexor of the ankle, while any tendon that runs posterior to the axis of the ankle joint will act as a plantar flexor. And the power of plantar flexion in each of these tendons will depend on the perpendicular distance or the moment arm of the respective tendon. Any tendon that runs medial to the axis of the subtalar joint is an inverter, and any tendon that runs lateral to the axis of the subtalar joint will be an everter. Once you've understood this, then you can proceed to thinking in terms of doing tendon transfers. The first thing that you need to do is test the muscle power. And you need to be extremely good at testing muscle power, and you should be able to record it very accurately. If in doubt, repeat it again and again. Use the MRC grading. You should be able to detect if the power of the muscle is grade 5 or less. Ideally, tendon transfers should be done only if the muscle that you're planning to transfer is a grade 5 power. You must remember that when you transfer a muscle, it is likely to lose one grade of power. So a grade 5 muscle, once it's transferred, may actually function only at grade 4, but this is still a successful transfer. So it's inherently, when you shift the tendon, it may lose a certain amount of power. So test the muscle power, the inverters, the dorsiflexors, the plantar flexors, and you can record this on this template that we had created. And you can grade it, mark the grades and fill in the shading into each tendon, depending on whether it's grade 5 or grade 0. And then you have the preoperative situation, and then you transfer one of these tendons and you look at the postoperative situation and see if you have achieved rebalancing of muscle power across the two axes of movement. Let's take example of foot drop due to a deep peroneal nerve injury. This child had a deep peroneal nerve injury on the left side. The left foot is slightly smaller. The hind foot is a slight valgus as compared to the normal side. What was paralyzed? The tibialis anterior, the extensor hallucis, the extensor digitorum. And the effect of this is that the child has a foot drop, and the everters are stronger than the inverters. Why? Because one of the inverters, the tibialis anterior, is paralyzed. So what was done was the peroneus longus was transferred to the dorsum of the foot and fixed in line with the long axis of the axis of the subtalar joint. So the tendon is transferred to the dorsum of the foot, anchored in the center of the dorsum to make sure that it is in line with the axis of the subtalar joint. So that's the postoperative position. So what have we achieved? Note the position of attachment, site of attachment of the tendon. It's in line with the subtalar axis.
So, sir, sorry to interrupt. Which bone you have transferred it to?
Yeah,
medial
well,
piriform?
Yeah, I don't worry about fixing it to the bone. I use an osteoperiosteal flap.
Okay.
Okay, so wherever you want to make your osteoperiosteal flap, it is likely to be in the lateral of
The line with the second toe, second ray.
Sorry?
So it's in the line of the second ray.
Yeah, it's a line of the second ray.
Okay.
Will be roughly the axis.
Right.
So balance is restored across the axis of subtalar joint because the dorsiflexor power has been augmented by the transfer. The plantar flexor power has been reduced because one weak plantar flexor has been moved away. So balance is now restored across this axis and this axis. Muscle balance is restored across the subtalar axis. How is that? Because the everters were stronger. You've taken off one everter, weakened it. Hopefully the muscle balance is restored. So that's the peroneus longus transfer to the dorsum of the foot. I always use this as a good illustration to show how the transfer works. But there's a technical mistake in this done by me. The tendon should have been passed under the extensor retinaculum, and it won't bowstring like this. But it's useful for teaching. So a mistake of mine has been used to the advantage of students. Is there another option? Yes, there is. You can transfer the tibialis posterior to the dorsum of the foot. And here I've opted to fix the tibialis anterior on the medial aspect of the foot. So the muscle balance is restored across the ankle joint because the dorsiflexor power is improved and the plantar flexor power has been decreased a bit. And across the subtalar axis, the muscle balance is retained. We have maintained the tibialis posterior in a position where the moment arm permits inversion. So the tibialis posterior and Achilles tendon produce some inversion, and the peroneum the eversion. So we restore muscle balance. So which of these two tendons would you like to do? A peroneus longus transfer or a tibialis posterior transfer? That brings me to the paralysis of the tibialis anterior. If you've got an isolated paralysis, you get what is called a dropped first metatarsal.
Yeah.
Drop first metatarsal. That is a classical example. So the balance of the first metatarsal or the first ray is like this when the tibialis anterior is functioning and the peroneus longus is functioning. When the tibialis anterior is paralyzed, you get a first metatarsal drop. And if you remove the peroneus longus, the balance of the first ray is improved. So by doing that transfer, you get a balanced first ray if you opt to do a peroneus longus transfer, as opposed to a tibialis posterior transfer. And for this reason, I like a peroneus longus transfer. You take an example of a common peroneal nerve injury, where in addition to paralysis of the dorsiflexus, you also have paralysis of the peroneum. So tibant, extensor hallucis longus, digitorum, and the peroneum are paralyzed. And the consequences, you've got a foot drop, inverters stronger than everters, plantar flexors stronger than dorsiflexors. You may, in due course, develop an equinovarus deformity. So what do? Transfer the tibialis posterior to the center of the dorsum of the foot. Okay? Remember here, you've got no everter power. You've got a strong inverter, and that inverter you're transferring to the dorsum. So the muscle balance across the ankle is restored. The dorsiflexor power is restored. Remember that this is a grade 4 power, but that's usually sufficient. And the plantar flexor power is reduced because you've removed the tibialis posterior. The muscle balance across the subtalar joint is restored. Why? Because there are no everters to begin with, and you've taken off the only inverter, and so you've got 0-0 inversion and eversion, so it's balanced. However, the joint, subtalar joint, is rendered unstable, and that might cause problems. So you need to stabilize the subtalar joint by fusing it. And here I've drawn a screw to signify subtalar fusion, and this was the Dennis screw across subtalar. You can see some graft in the sinus tarsal. If you've got an equine valgus, which you see in polio and not many other conditions, you get paralysis of the tibialis anterior, the tibialis posterior, and the extensor tendons. Everters are stronger than inverters, and that's where you get a hindfoot valgus and you've got a foot drop. So here we transfer the peroneum to the dorsum of the foot, but attach it onto the medial side, right? Okay. Now compare the point of attachment of the transfer tendon when you're doing a peroneus longus transfer, which I showed earlier on, where it's transferred to the center of the dorsum of the foot in line with the subtalar axis. Here we have intentionally attached it medial to the axis of the subtalar joint, because here you want it to act as an inverter as well. So you understand, by playing with the moment arm, you can convert the tendon, the function of the tendon, into a pure dorsiflexor or a dorsiflexor and inverter as in this situation. Calcaneal valgus is a difficult condition to treat because you've got an Achilles tendon which is paralyzed, and as I mentioned earlier, it's difficult to replace that. However, there's a very nice operation called a peroneal translocation, not very well known, but if done well, it becomes a very, very effective method of correcting a calcaneal valgus position in polio. So you can do a tendon transfer in any of these situations, and I've shown you the simple principles. You can also alter the moment arm of muscle. To give you an example, you've got a paralytic planovalgus, where the tibialis posterior isolatedly is paralyzed. You've got a flat foot deformity. So what do? Do a calcaneal displacement osteo, a medial calcaneal displacement osteo. What is the rationale? What happens is that the moment arm of the Achilles tendon has been altered to increase its inverter moment. And being a powerful muscle, it manages to do that quite well. You've not touched the muscle. You've just osteotomized the tuberosity of the calcaneum and shifted the tuberosity medial. So this is a calcaneal displacement osteotomy, which embodies the principle of altering the moment arm. There's one other situation where the moment arm is altered. This was done in cerebral palsy several years ago. And when it was first published, the authors got an award for it. It was published in the Orthopedic Clinics of North America, where they did a tendo-Achilles advancement in spastic equinus. Instead of doing a tenotomy or lengthening or anything, they detached the Achilles tendon and transferred it to the calcaneum just behind the ankle joint. So you shorten the moment arm and reduce the force of plantar flexion. And that was very effective. So I'm not going to take any more of your time. I hope I've given you some insight into tendon transfers in paralyzed foot. I'll leave you there. Thank you.
So thank you very much, sir. That's a great approach, and I suggest all the trainees to draw a diagram, as sir has mentioned, with the joint and mark all the tendons, make the power, and then you balance the foot. Now there are a few questions, sir, and I'll inquire. Now we see a lot of patients with calcaneus deformity early in their life, around 4-5 years. What is the ideal time of this P-body transfer or T-band to the calcaneus transfer? When we should consider it?
The earlier, the better. So if
Right.
you operate on a 3 or 4-year-old child into a P-body, it's a good idea, because a calcaneus deformity is a progressive deformity.
Yeah.
And it does badly, and an early transfer is a good idea, particularly in spina bifida, because you want to protect the sole from ulceration.
Right. Perfect. So that's what we would advise. Now, parents, sometimes they are not convinced because child is walking well with the orthosis, but we see the progressive callosity. Another question from Meet. In a case of CPN palsy, plan to tip post to dorsum transfer, what can be done if the length of tip post is insufficient?
In what condition?
Common peroneal nerve palsy.
Yeah. what I do is if you want to anchor it to the lateral side of the foot, you can attach it to the peroneus brevis. You don't need to take the tendon right down to the
bone.
bone. And you can anchor it to the peroneus brevis. It's quite effective. Similarly, if you remember Dr. H. Srinivasan, who was famous for his work on leprosy, he recommended attaching the transfer tibialis posterior to the tendons. He actually took it in two, one into the tibial tendon, one into the peroneus longus tendon. So you can attach it to the tendon. So length is not an issue, provided you do it, anchor it under proper tension.
Right. Now,
Yeah,
Dr.
Maulik,
Dhiren bhai, please.
Yeah. So this is a very common problem which we come across, that we are not able to get the sufficient length. So the first thing, I always carry out a adequate lengthening of the tendo Achilles, so that ankle is in at least 10 degree of dorsiflexion. That's the first thing. And the second point, which Dr. Jason Howard from DuPont recently shared with me, he said that what he does is he does suturing of the tendon at the distal end, and then he carry out a Z lengthening, or the split of the tendon, and then he rotate that portion so that you get at least 1 or 2 centimeter extra. And I have tried that in 2 patients, and that really works well. So this is another option, or the way which we can come over the problem of short length.
So can you reiterate again, sir, what to do in the distal end?
Okay, so let's say that this is a distal end. So we take 2 stitch over here, and then we split the proximal 2 centimeter, and then rotate that split, the half of the split, so that we get length. Usually we need 1 or 2 centimeter length, and this is a very good technique to do that, to get that length.
So another question is, when we do this transfer posterior to the anterior compartment going through the interosseous membrane, how frequently they work as a dynamic transfer, or they get fibrosed? What is your experience, sir?
You should be confident to get at least 1/3 of your tendons working dynamic. You should be able to make them those. And 1/3 of them, or a little more, may only act as a tenodiscs.
That's right.
When you test the child, you put the child on a stool and then ask the child to dorsiflex the ankle, the child may be able to do it. But when the child is walking, the ankle may not dorsiflex. The foot drop may not be there. So during gait, the phase conversion may not occur, because this is not a phasic transfer. The tibialis posterior is a muscle that functions during the stance phase. Whereas
This T-band is in dynamic swing phase.
Is the swing phase. So you're not a phasic transfer. The whole program in the brain has to change, and so it may not function. That doesn't mean it's a failure. If it doesn't, at least hold the foot up to neutral, that means there's a technical problem. But I think you should be able to get a phase conversion in at least 1/3 of your children.
Now, some of those patients with foot drop, where we don't have much power to transfer, how are the results of plication of tibialis anterior?
Never done it. If there is enough power, then I think it's a bit of a futile attempt. So I would rely on orthosis.
We had, as I learned from Dhiren bhai, and we have done in cerebral palsy, after releasing the long-standing equinus contracture, we have released the heel cord and then plicated the tibialis anterior, and that has prevented this valgus of subtalar joint in some of these patients. Dhiren bhai, you want to share your experience?
Yes,
that's a different situation. You're talking of cerebral palsy. I'm talking low motor neuron paralysis. If you don't have a power of grade 5,
but not
Remember
in
that most
paralytic.
of what we talk to tendon transfers relate to low motor neuron lesions, and the assessment of manual muscle power testing is applicable to low motor neuron lesions. It is not applicable to spastic.
Cerebral palsy.
No. So in fact, if you do manual muscle testing, you may be far off target. You may not achieve what's correct. However, in CP, plicating the lengthened tendon certainly makes sense. It certainly makes sense. There's no doubt about it whatsoever. But in a low motor neuron lesion, I don't think that's.
Yes, Dhiren bhai, you want to comment?
Yeah, just to add what Benjamin sir said, this plication in cerebral palsy is to take care of the length problem, not the problem of the muscle power. So the sir's lecture was probably on the tendon transfer, and that is to balance the muscle power. But in cerebral palsy, we do it to take care of the length issue.
And you have to do that in many situations. For example, pedal application in a crouch game. You shorten the tendon. So that is a principle that we would follow. Not in
Now,
normal.
so there's a question from Professor Anand Kishore Pal from Calcutta. He says the peroneus longus is a powerful during push-off phase. How it can be managed during peroneus longus transfer?
I didn't get, how can it be managed, meaning?
When we do the peroneus longus transfer, would it compromise push-off in early swing?
As long as your triceps surae is functioning, the push-off should be okay. I don't think the peroneus is a primary muscle that is responsible for push-off. It's the triceps surae or the gastrosolius. So if that is functioning, then it's not a major issue if we take out the peroneus longus.
Another question that in case of tip post transfer, what is the role of bone block procedure at sinus tarsi to prevent heel valgus?
Yeah, if you're going to make the subtalar joint unstable, then you can stabilize the subtalar joint by preventing it going to valgus valgus. And so that's where, I mean, I showed it with the screw and I suggested you do the Dennison technique. But yes, if the subtalar joint is unstable, you need to make it stable.
Yes, Dhiren bhai.
Yeah, so the first technique, what sir explained, that we need to fuse the subtalar joint so that we don't need this eversion power. The second technique, which is a Bredl's technique, in which what they create a yoke. So there are three tendons. On medial side, there is a tibialis anterior. In the center, the tibialis posterior, which is transferred from interosseous membrane. And on a lateral side, there is a peroneus longus. So these three, they form one medial column, one acting on a center, and the other working on a lateral side. And that also provides some subtalar stability in case of we don't have an adequate balance for inversion and eversion.
So we are trying, like we are relying on the tendons to provide stability. So it's kind of dynamic stability. But okay. So, Dhiren bhai, you have to share those papers with us.
Sure, definitely.
And that we'll share with the fellows. So we will move on to presenting a couple of interesting cases which our fellows have prepared, and you can advise how we could have done better with this. Dr. Joseph, sir, you have to stop sharing your screen so we can.
Yeah, you can close it.
I think you have to do from your laptop.
I have to do that?
Yeah, that's done. So Joanne,
Yeah.
now you can share your screen.
Hello.
Yeah, is it Mandar?
Yes.
Mandar, I saw your case and I forwarded to Dr. Joseph, sir.
Okay,
And
fine.
we are short of time. We'll rush through, but I'll forward your case to sir, and he will opine, and I'll send that message back to you. Yeah. Oh, sorry for that. Yeah, Joanne, please go ahead.
Good morning, sirs. Presenting a 15-year-old girl, she presented with a right foot deformity and weakness and abnormal walking pattern. She underwent surgery for myelomeningocele at the age of 6 months and followed by a foot correction surgery at 5 years. Both these surgeries, the documents were unavailable when she presented to us. And on examination, she had a right knee varus and a flexion deformity of 20 degrees, and there was some crepitus on knee movement. The power of hamstrings and quadriceps was 4/5. She had a right flail foot with clawing of toes. The power of all the muscles across the ankle were 0/5. She also had decreased sensations on the dorsum of the sole, dorsum and sole of the foot. And these are weight-bearing images. So,
Yeah. So as we can see that she is having this deformity on right side, and which is producing some callosity and trophic also on the dorsum of the great toe, and there is mild valgus of the left side as well. So how we should approach this, Dr. Joseph, sir?
How much of this is passively corrected?
It's very stiff and rigid deformity.
Okay, stiff, rigid deformity, very little correction. Is there external tibial torsion?
We did not find it clinically significant.
You must check this very carefully, because in the situation that you see how the child is standing and walking, child is dragging the foot in external rotation.
Yeah.
So is that the foot alone, or is there a tibial component to it? Because if it is, you must do a derotation of the tibia in addition to whatever.
This is the video. I did check, and the more it was from the foot than the tibia. I'm sure there must be some degrees of tibial extorsion.
Yeah, okay.
This is how she is walking.
So does she use an orthosis now?
Yes, but even with the orthosis, every now and then she needs orthosis repair, and skin breakdown is there. They are from remote place of Gujarat where they don't have quick access to orthotists. So they lost hope of making her better, but they came to see us. And then again, I took help of a senior orthopedic surgeon who was quite skilled in poliomyelitis management, because such deformities I saw in this polio foundation camps when I was very young. So what precautions we should take, and what things we can offer, and then we'll show you what we have done.
I'm surprised that you say that the deformities are rigid, because when you see the child walking, the foot is going in all sorts of directions. It seems extremely supple, in fact, too supple.
Yeah.
Because my approach is, if there is anything that is preventing the foot from becoming plantigrade, it will be essentially looking at the soft tissue and correcting it. I would be very reluctant to do bony surgery on her. I would like to make the situation where your orthosis works well, because if you can hold the foot into neutral, the orthosis should also do that. And I would rely entirely on orthotic care. If she doesn't wear protective footwear with soft lining, she is going to ulcerate soon. Or if she's already ulcerated, that's not going to heal. I think we need to be a little aggressive about getting orthotic care proper. Never else you do. I'd be interested to know what you did.
So I was also of similar opinion that this clawing of toes, we will do the tenotomy of flexor tendons and try to put her in orthosis. But parents were reluctant that every few months we have to change, and you do something more long-lasting. So, Johannes, can you show what we did? So this were her X-rays. Yeah, can go ahead.
okay. So this is what.
So we performed percutaneous plantar fascia release and heel cord tenotomy, and then we performed pantalar fusion like this. And somehow all these patients where we have performed pantellar fusion, they are very happy because they are walking well with the orthosis. Now, as you say, we see external rotation, so there must be the underlying tibial extorsion. So now family is happy that she can walk without anyone's help with a stick. And the problem is now with her knee joint. Can you show the X-ray of knee joint?
Yes, sir.
So this is the other challenge we have. She has this CMT joint, and I don't know what to do with this.
Marlon, what is the longest follow-up of your pantellar fusion?
So I have been taking help of Dr. Prakash Amin, who is a senior orthopedic surgeon, and I have done, we have started doing this before 10 years. So at least I have 10 years follow-up. Now this girl is 1 year follow-up, but we have many similar pantellar fusions.
Because I would refer you to an article by a gentleman by the name of Maynard, M-A-Y-N-A-R-D, who talked of the foot in myelomeningocele. Very simply, if the foot is plantigrade and supple, the frequency of plantar ulceration is next to nothing. It's almost zero. If the foot is deformed and supple, about a third of them will ulcerate. If the foot is rigid and plantigrade, there is still a high proportion of ulceration. And if the foot is rigid and deformed, there's a 100% risk of ulceration. So look at the statistics of Maynard.
Right.
And one of the things that I caution very emphatically is do not fuse the foot if there is loss of sensation, because the risk of plantar ulceration is exceedingly high. The child may walk much better, no doubt about it. But if you're going to condemn the child to plantar ulceration, I think it's a dangerous trend. The second thing is, in a neuropathic situation, if you fuse a joint, the proximal joint is likely to get into trouble. And that you're seeing quite nicely here, where the knee is now going to take the rap. So I am certainly against using any joint.
So that point is well taken, sir, and I'll go through the paper you suggested. But what I can tell you from my limited experience, all these patients, shorter term, they are very happy. And the families are also very happy.
I'm certainly agree that they would be happy with the way the foot is behaving. There's no doubt about that. It is more stable. It looks nice. It doesn't wobble all over the place. But if they start ulcerating, it's going to be a major problem.
Yeah. So
please look up that article by Maynard.
Yeah, I'll go through, and I'll also fetch out all my patients, which we have done before 5 years.
With specific reference to looking at plantar ulceration.
Yes, I'll do that, and I'll share access of all my patients. So, Dhiren, you have some comment?
Yeah, this is like, see, the situation what we have created. Yes, definitely the patient is better at foot level, but this is resulting into a situation, Charcot joint, which is again like a ulcer.
So this is, Dhiren, just a moment. This was there before. The knee was not good even before. So it's not that has been created or worsened after foot surgery. It was there, but I didn't know what to do for this knee joint. But at least every time she would walk, she would have an ulcer on the dorsum of toe. So we try to first correct the foot, and then to take your opinion that what to do from the knee joint. So how to deal with this knee joints, sir? Can we do anything for this?
Again, you might have to brace above the knee to prevent the knee from getting worse.
Right.
Yeah.
So that's what I have advised. Again, the orthosis is too bulky and the weight is too much. So even though we prescribe, patient tend to walk with AFO.
I know they may not like it, but
Yeah.
you got to protect the knee. The more it wobbles, the more it's going to become unstable.
Right.
So, yeah.
Right. So let's move on for next quick case because it's 5 minutes left. So one more case, sir, and so this is one of my friend's daughter. So yeah, joins.
Yes. So we had this 11-year-old girl. She presented to our OPD for the first time with a foot deformity, and she walked with mild interning of the foot and small-sized right foot with minimal calf atrophy. The power of tendo and peronei were 5/5, and tib posterior FHL and FTL were also 5/5. Tib anterior and lateral toe dorsiflexus were 4/5. She didn't have any sensory deficit and no bladder bowel issues. And she was a proficient dancer and a karate player. We got MRI, which revealed a tethered cord, and for which she had undergone detethering at 11 and a half years. And she presented to us with progressive foot deformity.
So joins. So this is we see many a times that the child is asymptomatic till 10, and as they entered into the pubertal growth spurt, they start showing subtle foot deformity, which brings them to us. And when we check the spine and we get a screening of spine, we see tethered cord, and we first refer them for the detethering. One of our patients also started having bladder issue when she was 13 years old, 12, 13 years old. So this is how she is now, sir. And do we have, yeah.
So she had an inversion deformity, which was correctable with a passive dorsiflexion of 10 degrees, a rigid cavus with a tight plantar fascia. This is a gait video.
So there is hyperextension of great toe is probably showing that the tibialis anterior weakness, right, sir?
Yes, yes.
So this is what you referred to as in your talk about kind of isolated dorsiflexion weakness. Do we have another video, Joannes?
So gait only we have one.
Okay. So with the Coleman block test, we could partially correct the heel varus, not fully, because the cavus was fairly rigid. It was not correctable, but inversion was certainly. So how we should approach this patient, sir?
Do a plantar
Fascia relief.
release to get the cavus correct. And I might be inclined to transfer the EHL to the metatarsal, the Jones transfer.
Okay.
In which case it will pull the metatarsal up and the cavus, medial cavus should decrease.
Okay.
Yeah.
So like this was a time when I went to Delhi to attend this Vince Mosca's Paralytic Foot Symposium, and he shown a similar case where he suggested peroneus longus to brevis transfer and plantar fascia release. And if the cavus persists, then in second stage you do the plantar opening osteotomy of cuneiform to make it a balanced foot. And so that's what we planned, because she had a very stiff cavus. So I did percutaneous plantar fascia release. We did peroneus longus to brevis transfer, as you have shown in your talk. And then After plantar fascia release, the first ray was still down. So I did a plantar opening wedge osteotomy and placed a triangular graft from crest, which actually aligned the inverting foot to a neutral axis. That's what Vince also said, that when we, and I asked him that, can we do a dorsal closing wedge? And he said, when you close, invariably it ends up into a bit of adduction deformity. So you better perform an opening wedge, so it will correct the adduction and it will better align the foot axis. So that's what we did. And Joanne, do we have, this is her post-procedure gait. This is how she walks. She had deformity on the left foot. And today morning she sent her clinical pictures, static pictures, so that we can compare with the pre-op. Do we have the static pictures, John?
Sorry, sir. I think I couldn't put it here.
Okay, so her callosity has improved substantially. The foot size, which was looking smaller, is looking better. Do you have on your laptop, or you can share
Yes.
that?
So just a minute, sir. I'll just...
Yeah. So
Can you explain your tendon transfer longus to brevis?
yes. So
How did you do it?
So what I do is, we cut it underneath the fifth metatarsal base. We cut there, and we tie that the distal end with the periosteum of the fifth metatarsal, plantar side, and then the proximal part we tie with the peroneus longus, peroneus brevis. So it keeps the peroneus everter strength okay. At the same time, it doesn't make the plantar flexion of first metatarsal too weak, and then they develop this the dorsiflexion of the great toe, and that's how it balances the T-band and the peroneus longus, and then the structural deformity of plantar flexion corrected by the osteotomy.
So the peroneus longus is mainly to defunction the plantar flexor of first ray.
Yeah.
Like I showed you that if you take off, so that was the aim.
Yes, that's the same thing which we have mentioned. What we do, we the distal part of peroneus longus, we do not completely make it loose, but we tie it.
Yeah. My only thing is, if you can passively correct the foot, which you could do.
We could correct the inversion, but not the cavus, sir.
Not the first ray.
Yeah, first ray was rigidly going down.
Even after your plantar fascia release.
Yeah, even after plantar fascia release. So we talk to the family that on table we see if we can correct this passively, then we won't do the cuneiform osteotomy. But if we cannot, then we'll do the cuneiform osteotomy. And with the lamina spada, we make sure that this much of opening makes all the toes in balance.
If you could passively bring the great toe to neutral, if you could. When you see her walking, she was walking with the toe going up, great toe going up. Then the Jones transfer would dynamically lift the first metatarsal. So that would have been possible. If you say it was rigid and you couldn't get it, then you can't do that.
So it's a flexible with this, then Jones transfer should be done. So I agree with that. So Joanne, can you bring those clinical images? So we have done this for patients with purely dorsiflexor weakness, peroneus longus to brevis transfer in a few patients with good results. So this is her current X-ray, current clinical pictures we sent today morning. You can see the foot size is small, but foot is corrected. She has some callosity on the lateral border of foot, but family is happy. She had been wearing orthosis for almost 1 year, and this is the final picture. Today morning's picture.
Looks good.
Yeah, they They were very demanding because she was a dancer and a karate. So, but they are happy apparently. There's not coming back with the complaints.
Detethering is effective.
It seems so. Her bowel, the bladder accidents has gone off. So I think we have a pediatric neurosurgeon and we take his help, and I think that has worked.
So good.
Right. So we are so happy to learn this from you, and we will now I will draw the subtalar axis which we were not drawing, so that makes me understand more about when and where to transfer those tendons. And I try and dig out my longer term follow-up of patellar fusion and share those pictures with you. And I hope they are not developing plantar ulcers. So thank you, Dr. Joseph. Thank you very much for your time.
Thank you so much. Bye.
Take care.